Let's start with this wonderful topic, migraine. In 20% of migraine patients, what happens is that they see these peripheral lines in the visual field, which is called migraine aura. And the migraine attacks sometimes they are so severe that patient literally locks himself up in the room. So migraine is pretty severe in some cases, and the exact etiology or why this happens is not known. We'll try to understand what exactly happens in migraines from the very basic. Let's say this is the brain and this is the peripheral part. Now in the brain we have what? We have a trigeminal neuron which has CGRP, calcitonin gene related peptide inside it. These, when released, it acts on its receptor on blood vessel and neuron. So they have CGRP receptors, the blood vessels and neuron. So when this act on blood vessel, there is vasodilation, and when they act on neuron, there is neuronal inflammation. So vasodilation and neuronal inflammation. Now when there is a vasodilation, there is increased blood flow, and this is leading to headache. So we have two problems: vasodilation and neural inflammation, which is causing migraine headache, and it is a unilateral pulsatile throbbing headache, which is migraine headache. So now what drug we are giving? See, for drug you have to remember this image. See, the car is going for a trip inside this blood vessel. See, there's a car going for a trip inside a blood vessel. So we have triptans or ergotamine. See, triptans are the main drugs, ergotamines are also used. See, what they do is, see, here we are lucky that in the blood vessel and the trigeminal neuron we have 5-HT1B receptor. So the triptan is blocking this 5-HT, sorry, triptan is stimulating this 5-HT1B release receptor, and here it is inhibiting the release of CGRP, and here it is causing what? Vasoconstriction. Done. So one problem of ours is solved, that we don't have vasodilation. Now triptans are doing vasoconstriction, and they are also stopping the release of this culprit CGRP, which is responsible for all these things. So now the problem is that blood vessels are not just in brain, they are in peripheral parts also, right? So this triptans is gonna do vasoconstriction in the peripheral blood vessels. So the heart blood vessels, if this is constricted, then blood flow is decreased, right? So we don't give triptans in ischemic heart disease patients. There it can cause problems. So there is a risk of what? Coronary artery spasm. So this was pretty much the function of triptans doing its job. And why are triptans able to do this? Because 5-HT1B receptor are present in both trigeminal neurons and the blood vessels. Done. Now we have two drugs, triptans and ergotamines. Now why are triptans drug of choice? Because there is vomiting associated with migraine, and triptans will decrease it while ergotamine will increase it. So triptans are the drug of choice. Now one thing you have to remember is you don't give both of them together, triptans and ergotamines. You give either triptans or ergotamines, otherwise they'll increase the risk of this ischemic heart diseases, right? And so in triptans we have sumatriptan, naratriptan, elatriptan and rizatriptan. These are the triptans drug. Now this ergotamine is given with caffeine, which increases its absorption. So in migraine, if we are having acute attack, then if it's mild, then we give NSAIDs or paracetamol, so they'll take care of it. But if it's acute or severe, we give these two important drugs, which are ergotamine and triptans. These are the drug of choice. Now for prophylaxis we are giving propranolol. So these are pretty sure, these are, see, these drugs are pretty clear that whenever we are having severe or acute attack of migraine, we are giving drugs to reduce the pain, right? But why are we giving drugs for prophylaxis? Like we are giving propranolol here for prophylaxis. Why? Because see, in a lot of patients we are having migraine, they have migraine for like 2 to 3 times a week. So let's say if you are having migraine for 3 days out of 7 days, then your working days are affected, right? So we need to give prophylaxis to prevent this migraine attack. So for prophylaxis we have A, B, C of migraine. Now we are just learning the drugs that are given for prophylaxis of migraine, right? So from A we have antidepressants and anti-epileptics. B we have beta blockers. From C we have calcium channel blockers, CGRP antagonist and methyl sergite. Now see, these are the 5 class of drugs that we are giving for prophylaxis. Now we will study the individual drugs in this. classes. Okay. So now for the individual drugs, we have to remember this image. See, a man is kept in a prison and it is inside this valley. So pretty dangerous place, right? So from prison we have imipyramine, from valley we have valproate, and from topi or cape we have topiramate. See, he is wearing a cape. So topiramate, valproate and imipyramine are the antidepressants and anti-epileptics. Now this guy is obviously not having any fun here, right? So there is no fun. So for fun we have flunarizine, which is a calcium channel blocker. So four drugs are done till now: imipyramine, topiramate, valproate and flunarizine. So these three classes are done. For the next two we have what is the beta blocker. See, the propranolol is drug of choice among the beta blockers for prophylaxis of migraine. So you have to learn this as it is, that the drug of choice is what? Propranolol. It is a beta blocker. Now the last class we have is CGRP antagonist. So we know that this trigeminal neuron is having this culprit CGRP, which is released and causing all sorts of problem, right? So we don't want this to get released. So what we did was we covered this with a frame so that it can't be released. So this is the frame through which it is covered. So the frame has, it is a frame, galaxy, eclipse, and the frame is having a ear. So we have galaxy, eclipse, frame and ear. From galaxy we have galcanizumab, we have iptanizumab, fremanizumab and erinumab. Now see here, this was the trick to remember this CGRP antagonist, how we are placing the frame on this so that this can't be released. Now what does the represent is, here any represent that it is acting at level of neurons. ZU means it is derived from animal and MAB means it's a monoclonal antibody. So all these are what? All these are monoclonal antibodies. Now we are studying some new drugs for migraine. See, so what's wrong with our old drugs that we studied? See, these triptans and ergotamines, what they were doing was, we know trigeminal neuron and blood vessel both have this 5-HT1B receptor, which is a serotonin receptor. Now these drugs are acting here and causing vasoconstriction here and stopping this release here. The problem was these guys are causing vasoconstriction here also and in the periphery also, where we are getting ischemic heart diseases and all sorts of problem. So we made new drugs which is lasmidatin. This lasmidatin is like the medal that we are giving to people who invented this drug, because this drug is going to block 5-HT1F receptor. Now this F receptor is just present in the neuron, it is not present in the blood vessel. So this guy is not causing any sort of vasoconstriction related problems, right? So what this drug will do, it will stimulate this receptor and decrease this CGRP release, and we are not having the migraine related problems, right? So the drug is lasmidatin and the receptor is 5-HT1F receptor. Now another drug we are having, see, earlier we studied this CGRP antagonists. These were the monoclonal antibodies. Now there are some new drugs which are CGRP antagonists. So what they do is they don't allow CGRP to bind here, right? So how we are going to prevent it? We put this CGRP inside this pant. So we have the pant drugs which are going to inhibit this CGRP binding here, because they are antagonists. They will bind to this CGRP, right? So these are the CGRP antagonists, and they are used for acute attack and used orally. So we are done with this. Now monoclonal antibodies against CGRP, we have already done this. So now we are summarizing the entire 30-40 drugs that we learned in this slide for migraine. So let's start. See, three things we are having: acute attack of migraine, prophylaxis and some new drugs. See, in acute attack, if it's mild we are giving NSAID and PCMs. If it's a bit more we are giving ergotamines and triptans. How are we going to learn this triptans? Blood vessel, they're going inside the trip. And why blood vessel only? Because they're causing vasoconstriction here, that will decrease blood flow in brain and that will stop the migraine, right? So triptans here. Now prophylaxis, we have A, B, C of migraine. From A we have two things, B we have beta blockers, C we have again two things, and M we have methyl sergide, right? And the drugs are, the valley we have valproate, the prison we have imipyramine, topi we have topiramate, fun we have flunarizine, And propranolol is the drug of choice, right? Drug of choice for the prophylaxis of migraine. So for the monoclonal antibodies of CGRP antagonist, we have this image, which is a frame, galaxy, eclipse, and the ear. So which are represented over here, right? So for the new drugs, we have one middle drug, which is last mediation, which is gonna block this F receptor and the 5-HT1F and won't allow this serotonin to exit out, right? And the another drug we have is CGRP antagonist, which are covering the CGRP receptor with these PANs. So these are PAN drugs. So this was all for migraine. So now the entire pharmacology that is relevant for the NEET PG examination is available in this playlist. You can also watch these lectures for university exam, but it is designed specially for NEET PG. So your university will obviously be cleared from these lectures. It is obviously having enough content for that, but your NEET PG preparations are going to be very ultra max pro clear from these lectures. Okay, so thank you guys.